Welcome back to another episode of Oncology for the Inquisitive Mind. I'm Michael, that's Josh, and this is Phase 2. Not a Phase 2 study, but the second phase of our Plenary double header. And we've got two more studies that we are very excited to speak about. Josh, first off, it's very late, it's very dark, it's very cold.
Melbourne.
Unlike Chicago, probably. How are you doing?
I'm good. I was just thinking, in every series you ever read or watch, the second book, the second movie, the second show, it's never as good.
Well, it depends. If it's a trilogy, generally the second one is the peak and then it drops off at number 3.
Yeah, true. Or it's just kind of like it's buffering. It's like a sandwich. It's like, you kind of want what's in the middle, but you have to go through the outside to get there. But either way, we've got I'm really well. That was just a thought bubble. But
yeah, I don't think we're going into culinary analysis this episode.
Not yet. That's next. That's the third of the trilogy.
That's the ASCO special. But yes, we have 2 more studies. If you haven't listened to our first episode, we obviously thoroughly recommend that you go back and listen to that.
Best episode in the world.
Well, at least until this one. So, Josh, why don't you get us started with a study that I think has got your creative juices flowing, and that is Serena-6.
Yeah, so many juices, so much flowing. Michael, Serena-6 is an interesting study, not just the outcome itself, but the design that they've used. And I think that's what really got me excited, is that we're finally looking at ctDNA to try and guide therapy. You have all these conversations. Everyone's doing ctDNA. They want it to be the next Ben-Hur, bigger than Ben-Hur, so to speak. And it just hasn't really got where we need it to be cost-wise or otherwise. So Serena-6 is a breast cancer trial, my favorite child, one of my favorite children. And it was camizestrant, which is a SERD, a selective estrogen receptor degrader, plus a CDK4/6 inhibitor for the treatment of emergent ESR1 mutations during first-line endocrine-based therapy and ahead or of disease progression in patients with hormone receptor positive, HER2 negative advanced breast cancer. Now, ESR1 has been around a little while. There's some drugs on the market already, but essentially the issue is this mutation only really develops after disease progression or your cancer is becoming resistant. And so most of the time they use these SERDs in the context of when you've either got a high ESR1 or second or third or fourth line, right? And so you don't kind of stay on the first line trial. But why don't we start at the takeaway points, and then I'll talk about the details of the trial. So what they found is that switching from an aromatase inhibitor to camizestrant and continuing the CDK backbone, guided by the emergence of an ESR1 mutation during the first line therapy, improved progression-free survival in this cohort of patients. The clinical utility of using ctDNA to monitor this can help affect and sort of determine when we should switch therapy, or potentially when we should switch therapy. This may even become a new treatment strategy, but there are caveats, Michael, and that's also the reason I like this trial. They've kind of pushed the boundary, but there are caveats. So the background, I've already mentioned a fair bit of this, that you get ESR1, up to 40%. It's rare originally at diagnosis, but then on progression, it's 40%. Good, I remember what I wrote / have learned over many years. This trial was a screening trial, so 3,000 patients in surveillance who were on therapy. They all had an AI CDK4/6 inhibitor, one of the 3, majority palbociclib, likely due to when this trial started. And they were sort of taking an ESR test every sort of 2 to 3 months. 51% were positive at the first test, 38% positive between test 2 and test 5, and 11% were positive after 5 tests. I didn't really understand that, but I'm wondering if it's like 51%, do they continue with the same cohort of patients, or is that kind of a slightly different cohort of patients and they were sort of continuous positivity? I'm not actually 100% sure, and I'd have to go through the protocol and how they did that.
Because if they've got 3,000 patients in surveillance and then half of those are positive on the first test, that's a lot of patients.
Right, exactly. And so this is obviously a live thing that we're listening to, so there are going to be details that we do miss slightly. But at the end of the day, there were 315 patients that were randomized to either camizestrant plus a CDK plus a placebo for the AI, or continuing the AI plus a CDK alone. Right, they were stratified visceral versus non-visceral, ESR1 mutations detected at first test versus subsequent tests, and PFS was that primary endpoint, and all the secondary endpoints were as you could probably guess if you listened to our show. And if you don't listen to our show, it's just overall survival and progression-free survival and safety. Pretty much everyone's like that. So well-balanced characteristics. 60% of patients had been on a CDK4 CDK4/6 inhibitor for at least 18 months, which is a good thing because you don't want someone to have rapid progression. You switch them to this trial, they probably won't have a response because their molecular biology is going to be very different. And it's the same as if you've got someone who's had it for 5 years. It's sort of, you have to sort of figure out somewhere that's the median. The average time someone stays on a CDK4/6 inhibitor is about 2 years, but can be longer. The primary endpoint, which was median progression-free survival, that was 16 months versus 9.2 months with a hazard ratio of 0.44. So pretty schwanky. Not bad, right? And if you look at the forest plot, and that's all really favoring camizestrant and a CDK4/6. And it also favors both Pelbo, Ribo, not so much Abema, which crosses that confidence interval, but there was a very small cohort of abemaciclib patients, so I wouldn't count them out just because of where they are. There's also a number of different ESR mutations, and it looks like it didn't really matter where they were. So there was consistent benefit, and there was benefit in time to deterioration, predominantly being pain of 23 months versus 6 months in the AI arm with a hazard ratio of 0.53. The PFS2 was immature. And I'm going to stop here just for a moment, Michael, to talk about what PFS2 is. So it's progression-free survival really after you've progressed on your first-line therapy, right? So it's like, how long do you wait from being on this treatment to your next treatment? The longer that is, the better, because it means you haven't had to go through your other lines of therapy. If you switch someone to camizestrant while they're on first-line therapy, is that technically PFS3? Because you've been on for 18 months. I don't know if there's a solid answer to that because I think the whole biology and the way we treat cancer is changing. And therefore, maybe PFS2 is not the right way to look at these trials. And I will get to that a little bit later in my rambles.
Please continue with your rambles.
Thank you. The safety summary was pretty fine. It was similar between both the arms, about 10 versus 12%. Really nice trial to know that the adverse events of this particular drug did not skyrocket from the standard of care. We see this so often that every ADC, every immunotherapy has a list of potential poor side effects, and these people can be miserable. So that was a really nice thing. There was a slightly high neutropenia, but when they sort of adjusted it for exposure to the CDK, they found it was pretty much similar. It was mostly due to duration of being on a CDK, which is always a lovely thing. So switching from AI to camizestrant, guided by the ESR1 mutation during first line of therapy, has some evidence to it. We don't have overall survival data yet, but it'll be interesting. There are, of course, some potential issues. There's always potential issues, right? That is different ctDNA platforms. It's expensive. In Australia, it's very expensive. In the US, I think it's $3,000 USD. What about is it a class effect? So is it just this drug? Or is it all of those drugs? So can you just switch and change, or could you change from one to the other? And then technically you're getting ongoing response because it's a slightly different cert. Will it lead to longer overall survival? Potentially, potentially not. But I mean, it's promising, right? It's very promising. And there was a lack of crossover. So if there's a lack of crossover in the later lines, working out overall survival might be difficult because that way you're not actually getting a really good picture of when you should sequence these drugs and, what's that second line therapy, especially the hormone receptor positive. If they're HER2 plus, do they go on TDXD? It's going to be a really complex analysis, Michael. And so that's something else to really sort of talk about. When they looked at the serial ctDNA, how am I going for time? Still got time. I think I'm just a faster talker than you, or maybe I'm just not as smart. I'll go down that. Go for that.
I don't think that's true, Josh. I think that you say things more succinctly.
Yes, but also I was waiting for you to say how smart I was, so thank you for that.
Also that.
Yeah, so they tested the 3,000 people. 17% had an ESR1 mutation, and 9% of those had a concurrent anatomical progression. So they were automatically excluded. The whole 51% that had a positive ESR test, I don't know the answer, going back to the top of my talk, why that is the case. But I'm going to talk about my take-home thoughts and why I like this trial. I like it because it's the first trial I've seen in a long time where I could envisage, not now, but potentially in the future, we don't need scans. We look at a blood test, you see ESR or whatever it is at X level. You're like, okay, this will be your next line of therapy. This will guide what we need to do. You don't even need a scan because you're getting it at a point where you know it's run its course. Things haven't really grown. You jump to the next one. You kind of keep it controlled, because I could see a future where we have 8 lines of therapy. We cycle between them at appropriate times based on the biology of this cancer, and then they're alive 15 years later. Not with this drug, but just as a concept, which is quite nice. And, PFS2, can you use it? I don't know. Is it applicable here? That's sort of a bit of a contentious issue. I mean, I think it was, people start to think about it like, oh, there are all these issues. I'm really worried. I'm like, I think if you look at the bigger scheme of how they've actually designed the trial, I think that's really commendable. And maybe it won't show overall survival. We don't know. But it might. And it adds another arsenal of options for patients with not too many side effects.
Yeah, I completely agree. I do agree that this is the future, if not of surveillance, then certainly of progression detection. I think, to your point of seeing a future without scans, I mean, quite aside from all of the radiologists who are currently weeping, I do wonder how practical that would be, though, because, I mean, the counterpoint to that is, yes, you have this great test. You can sort of extrapolate progression by the presence of ESR1, but then when you progress on this treatment, as you will, how are you going to detect that? So you would need follow-up sort of ctDNA assays to detect that, and then, of course, it rolls on from there. So I think there will still be a role for radiologists. So if there are any radiologists listening, don't worry, your local oncologist is still going to keep you in business. But I think that this is certainly a very exciting way. And the other thing as well is I'm comparing this to how we used to detect T790M mutations for EGFR mutant non-small cell lung cancer. You had to go and fish for a direct biopsy of a metastatic site so that you could run the tests, whereas this is a peripheral blood test, which is just so much better in every conceivable way. So if we can really integrate this, and you mentioned it briefly, our next episode is going to be with friend of the show, Adam Brofsky, so I won't belabor the point, but we do touch on, the financial toxicity of this regimen as well. It's a $3,000 test every 2 to 3 months. So if the costs can come down, if the availability can come up, I absolutely can see this as a sort of surveillance paradigm, not just in breast cancer, but if we can extrapolate it, not necessarily with ESR1, but with other mutations to other tumor streams and other lines of therapy, then yes, we might not need as many CT scans.
That's it, Michael. But why don't we stop there? Because I know that our listeners really want to hear your next trial, which is
the last plenary trial.
NIVOPOSTOP. NIVOPOSTOP. Well, how do you pronounce it?
You are just so far away. It's NIVOPOSTOP, Josh.
Oh, like post-operative. Oh, yes. My goodness. That's
as opposed
brilliant.
To NIVOPOSTOP, the mythical Turkish city of NIVOPOSTOP.
Oh, but there's gold there, so it's all good.
So it's all good. Yeah. So NIVOPOSTOP or NIVOPOSTOP is the last. I'm just going to call it that from now on.
Oh, that's not embarrassing.
Laugh. It is the last plenary session that or the last plenary study that we're going to talk about. And it is slightly more niche than our other studies, which have been breast cancer, colorectal cancer, gastric cancer, because it is a head and neck squamous cell cancer. But it's, there's always room for more plenary presentations in these so-called orphan cancers. I mean, at ESMO last year, there was the keynote study on cervical cancer, which was rapturously and well-deservedly well received. So NIVOPOSTOP is the addition of nivolumab to the standard of care of high-risk resected head and neck squamous cell, which is and has been for about 20 years or so, surgical resection followed by chemotherapy plus radiotherapy. So yes, the chemo radiotherapy following surgery paradigm has not changed in more than 20 years. The presenter was a French gentleman who said that he gave his first presentation at ASCO more than 20 years ago on some of that original cisplatin radiotherapy data, and now he's giving his last presentation, presumably because he's retiring, on this. So it was quite a nice bookend, I thought. Despite this, there is still a 40 to 45% recurrence rate, and this is both local and distant. And, these patients, we're already talking about very morbid surgeries, very, very morbid chemo radiotherapy. I mean, the toxicity, if you can get away with your food tasting like cardboard, then you've done well. But the fact that it recurs both locally and distantly or distally is a significant concern. Now, PD-L1 inhibitors are commonly used in recurrent and metastatic settings, commonly in combination with chemotherapy in the first line or by themselves if the PD-L1 CPS is high enough in the second line. So we know that they have data in the metastatic setting, but can we add immunotherapy to the early setting? So pretty standard study design. The eligibility criteria, you had to be not particularly old, you had to be not particularly frail, you had to have a squamous cell cancer of the oral cavity, the oropharynx, the hypopharynx, or the larynx. I've written and the larynx, which makes it seem like you had to have cancer of all of those sites, which would just be terrible. But those are the 4 sites that you can have. Notable exclusions to that: nasopharyngeal cancer, which, as we have talked about in distant previous episodes, is really its own thing. It doesn't belong in this family, as well as the very rare nasal primary squamous cell cancer, which is, again, its own sort of separate entity. It's considered a separate disease state from these oral cavity and throat squamous cell cancers. Patients had to have pathological stage of 3 or 4 post-surgery. They had to have complete surgical resection, and they had to have high-risk features. The high-risk features being extracapillary extension, or ECE, or narrow margins or close margins in the surgical specimen. Patients were randomized 1-to-1, and the way they've structured the Nivo is interesting. You have 1 dose of Nivo before your chemo rads. The Nivo continues through the chemo rads, and they used high-dose cisplatin as opposed to weekly cisplatin, which is a contentious point. So you had 3 doses of 3 weekly cisplatin along with your radiotherapy, and then you had nivolumab every 4 weeks for 6 doses, and this was just compared to standard of care. Obviously a bit hard to blind that. There were no placebos, so this is an open-label study. A primary endpoint was disease-free survival, with the secondary endpoints being overall survival and safety. So majority of patients were heavy smokers. The most common tumor site was the oral cavity, and the majority of patients had a P stage of 4A or 4B at surgery. So these are very advanced cases. In terms of the results, it's a win for Nivo. That's the long and short of it. The 3-year DFS was 63.1 compared to 52.5%, a hazard ratio of 0.76, which was statistically significant. Interestingly, the benefit was largely limited to a superiority in local control. There was very little difference in the incidence of distant recurrence. So whether there is some sort of immune priming with the chemoradiotherapy, that is one hypothesis that was put forward. There doesn't seem to be much benefit if you're looking at preventing distant recurrences, but in terms of controlling the local disease or preventing a local recurrence, then then nivolumab definitely has a benefit in terms of DFS. Benefit was technically consistent across subgroups, but there were a lot of subgroups whose confidence interval crossed the line of equivalence. There were probably lots of subgroups with small numbers, but it's worth noting. The overall survival data was immature. The safety, there were higher rates of grade 3 serious adverse events and grade 4 treatment-related adverse events in the combination arm. The biggest differences were dysphagia, quote-unquote renal disorder. I'm assuming that's either renal impairment from the cisplatin or immunotherapy-related nephritis, and asthenia as well. There was more of that in the Nivo arm. Now, that's pretty much the study. So there you go, Josh. You're not always quicker on your studies, but what can we take away from this? This is a potential new standard of care. I think it will be slower in uptake in Australia because of our ongoing insistence on having a once in a lifetime exposure to immunotherapy, which, we keep on saying surely at some point that's got to be loosened, but it doesn't seem to be happening anytime soon. But overseas, where you don't have those restraints, then yes, potentially a new standard of care. The benefit appears to be consistent regardless of the PD-L1 CPS. Interestingly, patients with a CPS of 1 to 19 did better than a CPS of less than 1 or greater than 20. So they said there was a trend to increasing benefit with increasing CPS, but that didn't seem to be the case to me. I guess as I said with the atomic study last week, or last episode, because we're releasing multiple episodes a week. Lucky you, listeners. But what do we do for patients with a rapid recurrence on this combination therapy? The honest answer is you probably have very, very few treatment options left, because platinum is the sort of the backbone of therapy for patients in the metastatic or the locally advanced unresectable setting, and now using immunotherapy as well. So you're probably looking at clinical trials at this point. So the summary from the discussion, I guess, of the study, the NIVOPOSTOP study, Josh, is how you pronounce it, NIVOPOSTOP.
NIVOPOSTOP.
Is that you need a MDT to determine what is best, whether it's sort of, do you have neoadjuvant therapy? There was another study, Keynote 689, that looked at this, and I won't go too much into that, but if you have a rapidly progressing tumor, you probably don't want to risk neoadjuvant therapy, because otherwise, if they progress through that, the surgery is going to become more and more morbid. So you need an MDT, you need experienced surgeons, you need PD-L1 testing, because, again, if you've got a high PD-L1, you might be more willing to go for neoadjuvant therapy. And you need to take into account patient, clinical, and disease factors, as we always do. So that is NIVOPOSTOP, another potential standard of care, new standard of care. And it's nice to see the head and neck space being presented. Or being represented, I should say. So that concludes our plenary double header. We mentioned it before, but we hope you'll join us next time, because we are welcoming back to Oncology for the Inquisitive Mind Dr. Adam Brufsky, and we're going to get his take on the breast cancer goings-on at ASCO 2025, the first of several high-quality international and local guests that we've got lined up for you over the next weeks, probably to months, let's be honest. That's how it always works out. So we hope you will join us on this journey through ASCO. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.